Okay, welcome everybody. Welcome to this Healthy Urban Places seminar today. Today we've got a bumper set of speakers who are all going to be talking to you about their work around healthy homes and health. So this is going to be a slightly different setup to our normal procedure. We're going to start with got three speakers today. So we have first on the agenda, we have Dr. Ella Foggitt, who is a Senior Research Fellow working with us at Bradford Institute for Health Research with a background in policy relevant applied research in the field of sustainability. And Ella leads our NIHR funded Healthy Homes project, which you'll hear a little bit about in a minute. And then we are delighted to welcome Dr. Olivia Swann from Edinburgh. So Livy is a Senior Clinical Research Fellow and Honorary Consultant in Paediatric Infectious Disease. And you're going to be presenting us some of the findings from your ongoing work into heating in homes and respiratory infections. Very excited to hear about that. And then finally, we are really happy to welcome Dr. Isobel Braithwaite, who is going to be joining us online. And she is an Honorary Fellow at UCL and Public Health Consultant, and she's going to be presenting some of the results of her research using longitudinal and linked data using the SAIL database in Wales. So without further ado, I would like to welcome our first speaker, Dr. Ella Foggitt, who's going to give you an introduction to our Healthy Homes project. We are going to segue straight into Livy after Ella's presentation, and then we'll have a little bit of time for questions before we go on to our final speaker. So welcome, Ella. Thank you.
Thank you. Okay, good morning, everyone. Not massively sure where to look, so I'll be here and the camera. But yes, welcome everyone online as well. As Rosie mentioned, my name's Ella, a Senior Research Fellow here at Bourne in Bradford. And I work on the Healthy Homes project, where we're working to understand the impacts on the indoor environment, health, economic outcomes, and carbon emissions of retrofitting social housing within Bradford. And I'm going to give you a little bit of a whistle-stop tour of this project, just to give you a sense of some of the work that we're doing in this space here at BIB. Okay, so we've got a real interest here at BIB in indoor environmental conditions and indoor air quality, in part developed through a previous project of Ingenious. And this project has enabled us to sort of continue that interest in indoor environmental conditions in the context of changes to the fabric of homes and how those two dimensions interact. And then there's, of course, a strong sort of policy imperative for this work in terms of net zero by 2050, housing contributing about a fifth of carbon emissions, and from a health perspective, housing-related health issues costing the NHS well over £1 billion. So that's a sort of very brief sort of backdrop to the work in this area. So we know that retrofitting has many positives. But there are also a series of sort of potential unknowns in this space as well, in terms of the pathways from retrofitting and how that moves into improvements in terms of health and well-being of the residents within them. So there are some questions in terms of possible take-back factors, whereby if people see their energy bills reducing as a result of their improved energy efficiency of their home, as to whether they may, instead of sort of pocketing those savings, they may actually increase the thermostat on their boiler. And so there's question marks as to how that might translate in terms of carbon emissions, for example. And then also, if retrofitting, particularly in terms of improved insulation, isn't accompanied by appropriate ventilation, then there may be some challenges around homes overheating in the summer periods, and also sort of moisture being trapped within the homes during the cooler periods particularly, and potential knock-ons for mould and damp as well. So these are some of the areas that we're trying to explore through the Healthy Homes project. And this particular opportunity arose through partnership with In Communities, who are a large social housing provider in Bradford. And they're in the process of bringing all their housing stock up to an EPCC by 2030, and are currently rolling out a 3-year programme that started in this financial year and is running through to 27-28. And it's that programme that we are working to evaluate in the Healthy Homes project. So, Healthy Homes, it started last summer, and it's running through for 4.5 years, and it's funded by NIHR. We're split into 4 work packages. The first work package, we're exploring the impacts on the indoor environment, energy use, and self-reported health on retrofit of social housing. And we're doing this by installing monitors in homes for a period of up to about 18 months so that we can track the indoor environmental conditions from before the retrofit occurs to during and after the retrofit occurs. And we're comparing this data to homes that will be receiving the retrofit after we finish monitoring. And we're also doing a series of surveys and asking for meter readings from the residents in those homes as well. Work package 2 is perhaps the most relevant work package to today's talk, because we're particularly focused today on linked housing and health data, but work package 2 hasn't kicked off yet, so hopefully we'll be able to have another one of these sessions in a year or so, where we can present the findings coming out through that. But for work package 2, we're drawing on connected Bradford health data and linking it with housing data to understand some of these longer term impacts of retrofitting on health and healthcare use. Work package 3, we're looking at, again, some of the longer term, but also shorter term impacts on environmental indoor conditions, health and economic impacts as well. And work package 4, we're looking at some of the broader contextual factors around the implementation and outcomes delivered by retrofit through interviews, through systems mapping workshops, and also through citizen science projects, where we're recruiting in communities residents as peer researchers, and they'll be co-designing and co-delivering research projects with other in communities residents. So we're really excited that will be kicking off in the next month or so. So the recruitment and data collection for work package 1 is still very much ongoing, it's live, but I thought I'd give you a little flavour of some of the data that's coming through. This is just from up until the end of February, and we're still collecting this data. But just to give you a sense of what's coming through from the residents who've been recruited so far, we have an average age of about 58. Majority are female and are white, with almost half living in single occupancy homes, 28% who have children under the age of 18. We've got roughly a third of people who are unemployed currently due to sickness, a similar percentage who are retired, and a similar percentage who don't have any formal educational qualifications. And in terms of the length of residence of the participants in our studies so far, average of about 12.5 years, but there's real variation. Some people have only just moved in and others have lived in their home for decades. And then looking at the indoor environmental conditions, again, within the homes that have been recruited so far, around about half have pets, 10% are reporting problems with vermin or pests, and then roughly 2/3 are reporting issues in terms of condensation and variations within the home in terms of temperature. We have over a half who are reporting challenges with drafts, and a similar percentage challenges with damp and/or mold. And so this is some data coming out through the sensors that have been installed within the homes. This data is only up until the end of January. We're currently very much in the middle of analysing the more recent data through to today. But this takes us up until the end of January. And with the red boxes are the outdoor temperature, the blue are the indoor temperature, and the green line indicates the WHO recommended 18 degrees within homes. And you can see that as the outdoor temperature drops, the temperature within homes over time is also dropping. So we're really interested to see how that is playing out through the latter part of the winter period. And we can also see that some homes are spending 100% of the days below 18 degrees as well. So that's been probably quite a lot of information in a very short period of time, but I just wanted to give you a flavour of what we're working on the Healthy Homes project. As I say, hopefully we'll have another opportunity to be able to present the research findings when we're a bit further through in this project, and also to present the findings in terms of the data linkage work that we'll be doing. But essentially, watch this space. There's lots more to come out. And if anyone has any questions, please do pop me an email. Really keen to talk and connect with anyone who wants to learn a little bit more about the project. So yes, thank you to all the participants who've joined the study so far, and to everyone else involved in the project. And I will hand over.
Perfect. There we go. Thank you so much. Thank you. Yeah, thank you so much. It's so exciting to be here, and thank you again for the invitation to come down from Edinburgh. I'm Olivia Swann, and I'm oh sorry, is it okay if I sit down?
Of course it is.
I'm a children's doctor and a data scientist at the University of Edinburgh, and this is just a brilliant chance to be able to discuss some of the work that we're doing in our new Home Heat and Healthy Kids study. It's worked. Brilliant, super. So I'm really here because as a doctor, I was fed up of sending children back to homes that were making them sick. And we were seeing the same children again and again, with respiratory infections coming in, and just being able to pack them up, send them home, and then seeing them a week or so later. And as Michael Marmot says, our homes provide the living environment that dictates our future health. I don't need to convince anybody here. So housing in Scotland, there are problems with housing stock throughout the UK, and everywhere has their own problems. In Scotland, the housing stock is particularly old. The climate is also it's different in different areas, but it's colder. On the west side, it's wet, and then up in the islands, there's a lot of wind as well. So there's lots of different challenges. And about 45% of homes are EPC Band D or below. And the last report was that 29% of all homes in Scotland are living in energy poverty. So in Scotland, we define it slightly differently. We don't use the Lively system. We use 10% of more than 10% of your income after housing costs. What's important as well is just to remember that energy poverty is not the same as income poverty, and that actually in the last report, 22% of folk who were in energy poverty were not actually in income poverty. It was their home that was making them unable to heat it. So I make no apologies. I'm a paediatrician. I think that children are the most important people in the world, but actually they're also hugely important to the pressure that they put on the NHS. And respiratory infections are the #1 reason for preschool children being admitted. And anybody here who is a parent or who knows young children will know that it's a constant battle in terms of the snot. So it's the oldest cause of admissions in children under 1 across Scotland. 40 in every 1,000 babies is admitted with a respiratory infection. It's the #1 cause of antibiotic use, so kind of driving antibiotic resistance potentially. And it's not just the child, it's really disruptive for families too, in terms of taking time off work, in terms of loss of earnings. And this is happening at a time when children's respiratory systems and their immune systems are developing. So the impact of early life respiratory infections is now understood a bit more, and they are associated with increased risks of adult asthma, but also of early respiratory death in adulthood, with recurrent respiratory infections in childhood. So it's got real long-term consequences too. So some of those mechanisms are due to that link between cold homes and respiratory infections that we were seeing anecdotally. So cold reduces the way that you can actually fight off respiratory infections. It stops you from being able to cough up and clear the mucus in your chest. And if you've got tiny airways to start with as a child, that is really important. Some viruses live longer in the cold, so flu and RSV are some of the ones that do much better in cold settings. It's estimated that approximately twice as many respiratory infections in children who are living in cold, damp homes. But while we talk about these numbers quite a lot, actually the evidence itself is less than clear cut. We still need to be able to look at that a bit more. And then an association between damp and mold and increased asthma. So increasing the risk of both developing asthma and also asthma attacks. So just going back to some of the things that Ella was saying too. So it sounds like it would be a great idea to make these homes warmer. And it absolutely is, but with caveats. So heating homes approximately 18% of UK's carbon emissions. In Scotland, the Scottish Government is committed to reducing energy use, reducing fuel poverty and supporting net zero targets. And these are just some of the ways of retrofitting homes here, but they're not all equal, as we were saying. So the ones highlighted here in red work by increasing the air tightness in the property. And potentially, if that's not done with appropriate ventilation, we end up trapping in condensation, smoke, viruses, and indoor air pollutants as well, and actually ending up with poor indoor air quality. So what are the health consequences of retrofits? So the best data that we have comes from New Zealand, and actually I've had the honour now of working with Caroline Fife, who has worked with Philip Howard Chapman's group, who came up with some of these data. There's really good links between insulation and reduction in colds and flu, and improving heating with reduced GP visits for asthma. But what's really important, and I didn't appreciate before I started this, is how different the housing landscape is in New Zealand. And we really can't just take that and put it straight into a UK context. So homes in New Zealand in these situations and these studies were often single single wood walls with tin roofs. So insulating those kind of homes will give you very different results to insulating some of the UK architecture. So just to bear that in mind. As well, there is evidence mostly from modelling studies that actually, in some ways, if we're going to retrofit and increase the air tightness without ventilation, that there's a prediction in increasing air pollution, increased asthma, and particularly in some of the bigger retrofits like loft insulation, increasing respiratory emissions as well. But critically, a lot of these studies don't include children, or if they do, they include them mixed in with adults, and they often include a mixture of interventions too. So some of the studies talk about kind of retrofit as if it is one thing, or weatherization as if it is one thing. So actually pulling out what that is really important. So this isn't just theoretical. I'm sure that you're all aware of the NAO report back in October, where actually there was a huge problem with mould and damp after cavity wall insulation in tens of thousands of properties. So actually this is real. There are many situations where we can see that actually the health could clearly be worse after a retrofit. So it's really trying to work out which ways are healthy. So why is this important? Well, so hopefully I've convinced you that children are important. Respiratory infections are the #1 cause of admissions with lifelong health effects. And we've got these two potential problems, either the cold, damp homes or airtight homes with poor ventilation, both of which can lead to respiratory infections. So what's exciting is that in Scotland, for the first time now, we can link up a child's healthcare, or actually anybody's healthcare data, with every single home they've ever lived in. So I know that you are able to do this with your EPRNs for your cohort here, but it's not yet possible on a population level across England. I know that in Sale they've been doing it for a bit longer, but this is the first time we've been able to be doing it in Scotland. So it's a really exciting new opportunity. So, this opens up a lot of doors, and I think at the simplest level, what we are now able to do is to use household level data to improve lifelong health. So this is a Wellcome Trust Early Career Award, so it's a fellowship for 5 years, to be running for 1 year. And it's the Homes, Heat and Healthy Kids study. So we've got three main parts to it. So the first is how to identify children who are living in underheated homes. And we're doing that through cross-sectional data linkage that I'll speak a bit more about in a minute, and trying to bring together, using routinely collected data, a risk prediction model to try and work out which children are living in homes. So the second one is trying to use causal epidemiological approaches to try and estimate how many respiratory infections we could prevent if every home was adequately heated. And then the third one is looking at how different ways of retrofitting homes across Scotland, what the different health outcomes are for those, and that's from a natural experiment perspective. And all the way through this, embedding in public involvement and early discussions with policymakers to make sure that we're producing outputs that can actually be used to answer questions, and not questions that we think are important, but actually questions that can change policy. So just for the first of those work packages, so what we're doing is we are looking at children under 5, so preschool children who spend the majority of their time at home, so they're not yet exposed to the school environment. We also know where they are, and I was just speaking to Emily, sorry about this just now, but we know where they are. So in Scotland, you have approximately 25 interactions in your under 5s with the healthcare service, and every time that happens, your address is updated. Okay, so we actually know where these children are living. That's not always the case if you're a 30-year-old man who hasn't been to the GP for 10 years. So we've got a good idea of where they are. And what we're able to do is we're able to link in their healthcare data. So on a national level, this is across the whole of Scotland, back to 2008. So about 4 million child years and almost 250,000 properties. So their hospital admissions data and their prescriptions data. So looking particularly at antibiotics and salbutamol in this age group. But also for a subset, we've got primary care data for the Lothians area, but not nationally. We can't do that yet in Scotland. And then linking up with property level data that I'll speak a bit more about in a moment. Outdoor air pollution data, climate, family finances. Again, I'll speak about these a bit more. Energy use from both from traditional meters and prepayment smart meters, and then household level data from the census. And these are some of the data controllers that we're working with, which has been really important to access these data sets. And then because this is the first time many of them have been used at a property level, there's been a lot of work going into trying to bring them into our TRE for reuse so that other people can come and use them in the future. So for the data nerds among us, hopefully this is what it looks like. So Kai is our NHS number in Scotland, and we're linking up census data with SMRA1, which is hospital admissions, linking up with immunisation data, child health surveillance data, prescribing information systems, and then we're linking across by UPRN to EPCs that I know we're all quite aware of their limitations, but they are better starting point than nothing. What's exciting is that we've been given access by the Scottish Government to use the HEED dataset, which is the Home Energy Efficiency dataset of every intervention the Scottish Government has funded across Scotland since 2008. So we've got those time points and the exact interventions that have been taken place. And then also the Scottish Government modelled EPC. So for any home that doesn't have an EPC, we've got the official model version of them too. NEED is the National Energy Efficiency dataset, which tells you how much energy a property has used in that year. And you can compare that to how much it is estimated to be using in the EPC. And then the Scottish Housing Conditions Survey, which is a subset of about 3,000 homes a year. It's a very, very detailed physical survey that takes place. We're using that to validate some of our models and some of our assumptions. Then linking across by either postcode or output area to some exciting small level area level data sets. And again, these are available kind of UK-wide and are really exciting. The more standard ones are the DEFRA air pollution data, which is on a 1x1 kilometre grid, the CEDA weather observations. But if you're not already aware, then the Smart Data Foundry is a fantastic new resource which looks at high street banking. For us, we're using on an output area level. It lets us look at income in an area and then what percentage of that was spent on energy. So it gives us again another proxy for energy and poverty. And then the energy poverty risk score, which comes from prepayment smart meters. And again, this is aggregated at the moment, but this is looking at patterns of top-ups and disconnections in our output area. So you can see the level of energy precarity in that area too. So all of these being a way to bring different ways to triangulate the risk of energy poverty into your analysis. So this is what we will end up with roughly. So these will have data at the level of the child, the property, the area. So demographics, socioeconomic position, admissions, prescriptions, immunisations, breastfeeding and smoking exposure as well. That's something else I should have said is what we can also do is, as well as seeing which home the child has lived in, we can see who else is living in that home. So you can look to the NHS numbers or the high numbers. You can see if there's multi-generational living. You can see if there is single-parent families. But you can also then link up those adults with their GP data on whether they're smoking. So you can see the smoking status too. And in the property, the type, the age, the tenure, as I say, the composition, overcrowding from that, but also from census, the level of insulation and the type of heating that they're using, their predicted versus annual energy use, and then the risk of damp and mold, which is modelled and not actually. And then at the small area level, energy poverty risk and some of the more environmental impact around pollution and climate. So it's there's a lot of data coming together, and it should be it's really rich. So sorry, I actually can't read that. So the next approach was more. So this is an incredibly oversimplified DAG, and I do have a really filthy DAG. I don't normally like to see it later. So this is massively oversimplified. But trying to use a kind of causal epidemiology approach to try and work out how many respiratory infections could be prevented if every home was properly heated. And as I say, these are the rough numbers that we are working. So this is using multi-level Western regression as a starter, using hidden Markov models as well. So those are all in development at the moment. And then just finally, as I was saying, this natural experiment approach. So looking to see different ways of making homes warmer and the impact on health outcomes. So at its simplest level, trying to divide these interventions into whether they increase air tightness or whether they don't. And then looking at, as I say, at the simplest levels and then going down deeper into different types of retrofit in different areas or different architect properties. So I'm not doing this on my own. These are some of the fantastic collaborators that I'm working with, and hopefully there'll be some of them who are familiar to you. So this is a new study. We've only been running for a year, and it's gone from being just me with these brains in the background, and now we have 2.5 postdocs and a PhD student, which is phenomenal. So big shout out to them as well. And what we want to be able to achieve at the end of it is our main aim is to reduce respiratory infections and to improve lifelong respiratory health, but also to inform policy and to make sure that children are involved in these just transition discussions about net zero policies. But what we also want to have is a really flexible infrastructure and a flexible methodology that you can use for different populations and different conditions. So, for example, stroke in the elderly or housing in a warming world. And trying to bring together a group of folk who are all passionate about these things. So that's our plans. This is just very, very early data from Ella, is our fantastic PhD student. So this is some of the prepayment meter data by SIND, so Scottish Index of Multiple Deprivation, and more deprived is 1, less deprived is 10. So you can see, as you would expect, that there's a high proportion of homes have prepayment meters in the deprived areas. But actually, the energy efficiency, some of the less deprived areas are the ones where they have less energy efficient. So we'll see that across the UK. Energy consumption follows more of a predictable trend in terms of those who are in higher socioeconomic groups are able to kind of spend a bit more on their energy. And then this is just the combined fuel poverty score that I was talking about, looking at earlier on. And then this is how it looks in terms of its spread. And it's more about the shape of it than the actual the cut-off of the score itself. And then just very quickly, we had a stakeholder meeting last year, which I expected to have 20 people and some sandwiches, and instead we had 130 in person, which is from 50 different organisations. So I've been quite overwhelmed by the interest in this, but there's always room for more kind of more work together. And then and maybe we could talk more about this in the questions, but public involvement is something we're hugely passionate about. And we were saying earlier on, sometimes it's hard to really speak to the people that you need to, and often PPI groups, in my experience, are retired professors or people who maybe haven't got the lived experience. So we're working through trusted third parties. We're working with, so through Shelter, through Poverty Alliance, working with fantastic families across Scotland who have helped set the research questions, who've helped to develop a scientific animation and made short videos about their experiences. And what's exciting is, as well as being able to pay for their time, we've gone on to work with them to use their expertise to get qualifications. So they've now got qualifications here from in community leadership. So it's just a really nice way of trying to be able to that meaningful those things. So sorry, so just to sum up, I think we can all agree that there's a lot of co-benefits here in terms of getting it right. So if we can get it right, we can reduce fuel poverty, we can reduce carbon emissions, we can ensure just transition and improve childhood. But if we get it wrong, there's a lot at stake. So just a quick thank you to some of the brilliant people who are involved, to our funders, to our community group, and then just to finally leave you with a brilliant quote from Lord Ed Boyle, which is, "Kids are the fuel in society's rocket. There's no second chance to support this change." Thank you.
Well, thank you. Some brilliant questions there, and we do have a bit more time for questions after our next speaker. And I'm delighted to see that Izzy's joined us. Welcome, Izzy. Izzy, I did introduce you at the start, but I'm not sure you were here. So I will hand over to you, and perhaps you could reintroduce yourself to the group. And we're really looking forward to hearing about your work.
Thank you so much. And yeah, apologies for the slightly late joining. Can you hear me okay?
We can hear you perfectly. Thank you.
Brilliant. So my name is Izzy Braithwaite. I finished up a PhD at UCL last year, and I'm kind of back working in public health now. I'll try and share my slides. Yes, they're just coming, I think. Yeah, great. So I think you've probably already covered quite a lot of the kind of rationale and background in the previous talk, but just to, if you click through the bullets here. So we know there's that really close relationship between housing and health, many different ways in which it affects health. And we know that there's particularly poor quality and energy inefficient housing in the UK, a lot of it relatively old, which is a key driver of both cold homes and fuel poverty. I focused in on respiratory health within my PhD analyses, partly because of quite high rates of respiratory health and the fact that they're kind of thought to be quite significantly impacted by housing conditions, to try and better understand some of that relationship. If you can click through, that'd be fine. So different kind of elements of that work, which was funded by NIHR, I should have said, and based at UCL. I started with a systematic review looking at kind of both temperature, energy efficiency, and heating in relation to respiratory health. And then a lot of the work was trying to kind of set up how energy performance certificates could be linked to routine health data within the SAIL data bank, which is based at Swansea University, and it covers routine data across Wales. So it was the first time that that linkage had been kind of made, and that was kind of quite a big part of the work, was getting that to happen. And then kind of finally trying to improve our understanding of how energy efficiency as measured by energy performance certificates is related to respiratory health, particularly looking over time at the development of common chronic respiratory conditions. If you could go to the next one, thanks. So kind of in the systematic review, I have some extra slides if we kind of have time and want to go into this, but really headline findings around the respiratory health aspects of that were that whilst there's reasonably consistent evidence when it comes to kind of indoor temperature and respiratory outcomes such as symptoms and healthcare use, it's still a relatively kind of relatively limited evidence base, even at the level of temperature. When you come on to energy efficiency studies, it is a much more mixed picture. And that might be for kind of many different reasons in terms of heterogeneity of those studies, heterogeneity of the interventions themselves, and limitations in terms of sometimes quite small numbers, potentially not necessarily well enough powered, and other kind of questions. Fairly few studies that actually looked at heating as an intervention, and again, not much consistency in terms of what was actually what was the intervention and was it the same across studies. So quite a number of gaps. Not many studies that looked at disease incidence. Primarily, it was more about kind of symptoms. Relatively sort of fewer of the studies had any longitudinal follow-up. Power was often kind of an issue, because I think in this space with environmental exposures like this, you are often talking about reasonably small effect sizes, but affecting quite large numbers of people potentially. And so you need to kind of have that built in terms of ensuring that there is sufficient statistical power. Confounding adjustment was variable, I think, and some of the potentially quite important things like tenure type or housing, kind of other housing factors weren't always taken into account there. And there's a limited understanding still in terms of mechanisms of effect. And I caught the last little bit of what Olivia Swann was saying, I think, in terms of indoor air quality, for example, monitoring of that certainly seems to be a bit of a gap of how do we actually draw that relationship between energy efficiency and the pathway than the more direct exposures. If you could go to the next one. Great. So kind of a very quick overview really in terms of that data linkage I'll start with, and then on to the kind of cohort study. So this project was a pilot kind of case using EPC data linked securely within the SAIL data bank, which is a trusted research environment for accredited researchers. And I worked with a team, particularly Rodri Johnson at Swansea, on that kind of linkage process in terms of data minimization and reducing re-identification risk and how what that kind of could involve in order to still produce meaningful results. The linkage was then undertaken by the GIS team at SAIL, and I received data with a split file process, so it kind of needed a couple of just additional steps to link it to people. SAIL has encrypted kind of person-specific IDs, as well as what are called residential anonymized linking fields, so house-specific IDs, and that's really, really helpful for kind of linking across data sets when you're interested in a data set that's at that housing level. So kind of methods-wise, did some descriptive data analysis, including looking at those that did and didn't have EPC records, and it was about 2/3 that did. A longitudinal study where I looked at both asthma and COPD, and that's mainly what I'll be kind of presenting now. And it was the first GP record of that was kind of interest for this study. The population were those, this is in the main analysis. I will talk a little bit about a kind of supplementary one that's just ongoing at the moment. So it was kind of restricted to those that were living in Wales as of the 2021 census date, who had an EPC certificate for that home at that time, over 18s, and they also needed to be at a SAIL-linked GP practice, which is around 80% of the GPs in Wales. The main exposures of interest were the wall insulation type and EPC rating, which we kind of split into 3 groups for the main study. So I'll talk about that in a bit. We used a DAG to select covariates, and then undertook some sensitivity and effect modification analyses as well, making use of the census data that we got access to. If you could go to the next one. So this is kind of just to sort of, briefly show the sort of working DAG for the energy efficiency respiratory disease incidence relationship, and what was adjusted for kind of based on this, avoiding kind of conditioning on things that that could have been mediators, things like heating type and indoor temperature, but we didn't have that data in any case. But I think it's a sort of schematic of potentially energy efficiency influencing a number of those things along the causal pathway. And so in the kind of what we said fully adjusted study, but we did do some additional adjustments with census data in a further sensitivity analysis that covered age, sex, tenure type, property type, building size, which is floor area, the local area index of multiple deprivation, or the Welsh index of multiple deprivation, and rurality. And yeah, I'm happy to talk a bit about sensitivity analyses and things as well. If you could go to the next one. So yeah, these are some of the different sensitivity analyses we undertook, a lot of the time using either some additional EPC data or census-derived data on things like socioeconomic classification, household occupancy, and the ethnic group. And then I think in F we had both those and fuel type, but different depending on the exposure because of some of the collinearity between those relationships, in those relationships. If you could go on to the next one, thanks. So, and I think this is what added in on the slides I've got on my computer, but just to kind of give you a sense of numbers, was after excluding those with a prior diagnosis, it was 636,000 in the main asthma analysis, 726,000 in the main COPD analysis. That was in the kind of quite simple initial analysis, which just looked at everyone present at that one date, so that the census data was kind of considered valid. But I have been doing some further analyses since then, looking at multiple spells, kind of any point in time over the follow-up period, which was from about 2010 until 2022. So that becomes a slightly larger population of about 1.3 million. And just to kind of give a sense of that cohort, median age was about 41, mainly in houses, 2/3 owner occupied, and about sort of 18% in social rented and 16% in private rented tenures. So that is basically slightly more skewed towards the rented sector than in Wales as a whole, and that's likely because of restricting to those with EPCs rather than covering the entire population. I did do a further analysis using inverse probability weighting to kind of check whether that affected the results, and it broadly didn't really seem to have a huge effect, kind of drastically changed the findings. So to go on to the next one. Thank you. So these are some of the kind of key just descriptive differences between those with and without EPCs. You can see that those not in the EPC group were a bit older. They were in kind of less deprived areas, but that's in the this one in the corner, women's quintiles. The people with EPCs were more likely to be in rented tenures, and the people without more likely owner occupied. And there were some slight differences in terms of economic inactivity, probably to do with the age, as well as the National Statistics socioeconomic classification. But there were broadly similar profiles around both rurality and educational level, and those aren't shown here. Keep going, thank you. So kind of overview of the main findings was essentially that there were kind of small benefits, but significant, seen in particular for COPD and for overall EPC ratings when we compare A to C group with E to G group, but also a benefit of being even D rated EPC ratings in COPD group. Just an update to this, I'm not yet able to present these results because it takes some time for kind of approvals, but in terms of the sort of multiple spells analysis, that looks relatively consistent with this. It does show a small reduction for asthma risk also in that cavity wall insulation group. For other wall insulation types, I didn't really see reductions in that risk, but that may well be a kind of somewhere where it's a bit underpowered. So I think even with these quite large numbers, where it's smaller exposure groups, so for example, if I was using A to B as the reference and then comparing individual bands, it's not really well enough powered because you've got relatively few homes in those more in the A to B and the F to G groups, which was one of the rationales for just splitting it up in terms of A to C, D, and E to G. At the bottom here, I've mentioned a kind of possible interaction with smoking status that seemed to kind of come through. There's a sort of slightly larger reduction that we see for nervous smokers, and not very statistically significant difference amongst the current smokers when you go from E to G to A to C. Obviously, though, that's on a rather sort of lower baseline risk for the never smokers, so may not be particularly relevant, but it just might perhaps speak to a mechanism around indoor air quality that I think needs further investigation potentially. If you could go to the next slide, please. So yeah, kind of underway some additional analyses using multiple imputation for kind of relatively small proportions of missing data, but they become a bit more significant in these sensitivity analyses, and also accounting for multiple spells per individual, which kind of increases the power a bit further. In general, the findings I've presented here do appear to be robust to these changes, but that's still underway. And if you could go to the next one, please. So kind of some of the key strengths and limitations. It's a new linkage, and I think there's quite a lot of potential in trying to kind of use routine housing data from EPCs with routine healthcare data. I think I didn't catch all of Livy's talk, but I think it sounds like she's been doing a lot of great work in that space. And a particular benefit I think that enables is around the statistical power and potentially kind of in terms of covariate adjustment. There are still obviously risks of residual confounding. There's the possibility of exposure misclassification because people's EPCs aren't always updated at the point where they maybe have work done. And so sometimes the kind of lag or the potential misclassification during those periods is certainly there. Similarly, with address data from based on GP records, that isn't necessarily fully up to date all the time. So there are some kind of issues around those things. Generally, I think those things would tend to bias towards the null, and so might make us think that if there's a true effect, it may be larger because some of those misclassifications would probably be non-differential. There's the kind of question about selection bias in terms of which homes have EPCs. And I did test that out with inverse probability kind of weighting, as I mentioned, to try and kind of account for that. So that didn't seem to drastically alter the direction anyway of the results. And lacking data on occupant practices, as well as on the actual kind of temperature and air quality measures within people's homes, means that it's difficult for a study like this to shed really detailed light on what's actually going on to drive those kind of effects, and there's possibility that it doesn't generalize well outside of the UK. But kind of notwithstanding that, I think one of the things that this study hopefully does do is kind of actually think about the development of disease over time, which has been less studied before, and I think that can, together with other studies, help make the case that actually investing in housing is a really important preventative intervention, not only in terms of those who already have conditions, but actually if we want to try and reduce the development of disease over time, then it looks as though these exposures make a small but still kind of population level meaningful impact on those risks over time. If you could go on, I think we're coming towards questions. Oh yeah, so this is a kind of schematic or conceptual diagram suggesting that there are kind of trade-offs potentially between the temperature aspects and the indoor air quality, kind of air tightness aspects from this, which might move in different directions, and that might underlie the findings, which appear rather kind of there's a clearer dose response kind of relationship for the non-smokers, never smokers, than the current smokers, and that plausibly could be explained by some worsening of indoor air quality offsetting temperature related benefits in that group perhaps, but obviously without being able to say for sure. So those balances might be different for different kinds of energy efficiency measures. They might also be different for different respiratory conditions, and that perhaps could explain some of the kind of difference seen for COPD versus asthma. If you could go to the next one. So kind of implications, I think there's a need to further investigate mechanisms and make use of linked housing and health data sets within that potentially, but probably also bespoke studies looking at that. Involving residents and communities, I think, is really powerful and important in this. And I did some work in parallel with a group in East London who were kind of trying to document the conditions in their housing and try and get change, highlighting the health impacts that was having. So I think the more that we can bring that in together with high quality and quantitative evidence, then the stronger the case there will be. I think health economic evaluation and evaluation in general when retrofit policies are being rolled out is very much needed, because I don't think we can just assume necessarily that there aren't risks as well as benefits. And so I think evaluation has an important part to play in that. And yeah, kind of whole home approaches, I think, are clearly what's important. There's definitely a need to prioritize ventilation and indoor air quality, looking at those kind of preliminary smoking results, and then thinking about occupant practices around things like smoking and ventilation should be taken into account in policies and programs. Next slide. Yeah, so thanks to NIHR and to my supervisory team, my PPI panel, colleagues at SAIL, and yeah, everyone else that's been involved in this. Happy to take any questions.
Okay, right. Well, thank you very much, everybody online. It's brilliant to see you. I hope you enjoy the rest of your day, and thank you, everybody. Thank you.